Today we are talking about emergency neurology. It is a very important topic that all of you should know every point in this lecture. Someone may say, I'll not be a urologist. Even if you are not a urologist you are not hoping to be a urologist, you may or you must face with cases like this in the emergency unit. I am Professor Wael Gamal. I'm specialized in the urology and in the stone field, but I have to know the emergency. I am the chairman of the urology section at the Egyptian Urological Association. I am also board member in the EULIS. EULIS is the European section of Ureteral. I am also board member in the International Alliance of Ureteral. Why I tell you all about my position? Because all of you must know you have to have a position in the societies in your specialty, whatever the specialty. What is the definition of emergency? Emergency arises when a condition requires rapid diagnosis and immediate treatment. The patient may ask you to postpone him till the next day, or after a few days you have to refer the patient for immediate management. We divide the lecture into two main categories: non-genital, including hematuria, renal colic, urinary retention, infection, acute renal failure, trauma. And the genital one, including phimosis, paraphimosis, priapism, penile fracture, and acute scrotum. Talking about hematuria, it means blood in urine. You have to differentiate between different types of hematuria, either macroscopic, that's seen by the patient himself. It is either gross hematuria or frank hematuria. Microscopic, that need microscopic examination, which means that the hematuria is mild. Very important, you have to know that the hematuria is painless or painful. For those with painless hematuria, it is very important in old age to maybe malignancy. For those with painful hematuria, we are thinking about something like stones. There's something associated with pain. Also, you have to know that initial hematuria may be related to the ureteral pathology, maybe terminal hematuria. It is very important in cases of bilharziasis. Maybe total hematuria, not initial, not terminal, but it is a total, mean there is a pathology that causes hematuria, total hematuria. Maybe it is due to medical cause, something in the kidney, or urological cause that's called surgical hematuria. Medical cause, very important in case of glomerular or non-glomerular, like those with interstitial nephritis, glomerular nephritis. When I think you studied this issue in the last year in the pediatric department when they are talking about glomerular nephritis. So when a child coming to you with still-like urine, what's called hematuria, you have to think in glomerular nephritis. The urological cause, like tumor, prostate, stone, trauma, tumor, all these points should be investigated. Very important when talking about medical cause of hematuria, it's mainly or mostly associated with what's called RBC's cast. Very important. Also may be associated with proteinuria. Investigating a case of hematuria, the patient usually presents with hematuria. The hematuria is alarming for a patient at the presentation. Maybe it may be massive hematuria associated with urinary retention. Maybe the hematuria due to renal cause associated with renal colic. How to diagnose or proceed with cases like this? First of all, you have to know the history of drug intake. You have to ensure that it is hematuria. It is not a concentrated urine, dark urine. You have to do urine analysis. You have to do lab investigation for bleeding. You have to go for radiology like CT, and even if nothing is diagnosed, you have to go for even cystoscopy or flexible ureteroscopy. And all of you know the treatment is the treatment of the cause according to the diagnosis. point in emergency in the non-genital is the renal colic. Very important, and anyone in emergency hospital should see cases like this. The commonest urological emergency, as I said, you have to see it at any place. The clinical picture, you have to know the clinical picture very well. Renal colic is severe in nature. It is not like any pain, it is severe. How you know that it is severe? The patient should go to emergency hospital or should seeking for medical advice even in the midnight. It is severe in nature. It is mainly posterior. It is not anterior pain because the kidney is a retroperitoneal structure. It is colic in nature. It is associated with other urological symptoms like hematuria, like stone passer, like previous stone operation. It is associated with other symptoms like GIT symptoms. It's associated with vomiting. It's very common association, the renal colic associated with vomiting. It is sudden onset, sudden offset, short duration. The patient responds to strong analgesia, not responding to rest or any other line of simple treatment. Differential diagnosis, sometimes there is a stone in the iliac fossa and in the lower third. There is differential diagnosis between it and other ovarian pathology, very important. Between the appendicitis, very important. The appendicitis, the patient is calm, leaning forward, the pain mainly anterior, and when we did total leukocytic count, the patient had leukocytosis. Sometimes there is differential diagnosis of diverticulitis or even the ectopic pregnancy. How to diagnose? By ultrasonography, you will find that the kidney is obstructed. When we do QB, if the stone is radio opaque, you will find the stone in the ureter or even in the kidney. And the most and the best way to diagnose is the non-contrast CT, because it can diagnose both radio opaque and the radiolucent stone. Also can diagnose the degree of back pressure or any associated other pathology. No place for intravenous urography during renal colic. In cases of pregnancy, this is the only indication for MR urography, because we cannot do CT for pregnancy, or the best is the MR urography. What is the cause of renal colic? Mostly the cause of renal colic obstruction. The most common cause is obstruction by stone, sometimes obstruction by clots, maybe obstruction by any pathology in the bladder, stricture. All these are causes of renal colic. The management of renal colic, most of the cases is treated at home. However, it is very important to know that some cases or in certain situations the patient should admit it to the hospital, and this patient is need for intervention. Pain that failed to respond to medical treatment, you have to have a limit for medical treatment if the patient cannot tolerate the pain, so it is one of the indication of intervention. Any fever, you have to put in your mind, any case with fever with obstructed kidney, it is an emergency and this patient is in need for intervention. Impaired renal function, either obstruction of a solitary kidney or bilateral obstructed kidney, this is an emergency. The medical treatment, if the patient is respond to medical treatment, you have to have a limit. The maximum allowed time for kidney to be obstructed, not more than 4 weeks. So if you give a patient medical treatment for 1 week, 2 weeks, 3 weeks, and this stone is just progressing but still the kidney obstruction, in this situation you have to send the patient for intervention. Decubation, student like all of you, he will examine after 1 or 2 weeks, and he is from a remote area. Doctor like me, professor like anyone, he have no time for medical treatment. So in all the situation, you have to choose the intervention from the start. It is the same management as we said. It is different cause. It is the treatment of the cause of this obstruction. However, in case of emergency, in case of renal colic severe, in case of fever, in case of stone solitary kidney, the first line of treatment is to relieve the obstruction. You have to put in your mind any obstructed system with the previous mentioned indications. You have to relieve this obstruction either by insertion of a double J stent from below or insertion of percutaneous nephrostomy tube to relieve the obstruction. Then the patient will tolerate the pain and they get a good general condition. So go to for definitive treatment. If it's stone ureter, stone kidney, whatever the cause, you have to treat the cause. Urinary retention is very important emergency in urology. We have two types of retention: acute retention and chronic retention. Acute retention is painful inability to void with full bladder. The cause of acute retention is very important. There is something infravesical below the bladder, either prostatic abscess, stone posterior urethra, urethral trauma, urethral bleeding. Any pathology below the bladder can cause obstruction. The second cause is very important, and all of you have to put it in your mind. You hear some patient in acute retention, the urethra is free, there is no stone, the prostate is free. So what is the cause? Don't forget the neurological cause. Sometimes there is neurological problem that the bladder cannot contract, like sacral nerve compression or reflex pain post-operative for those like postpartum or post-piles operation. The patient there is a pain and they cannot micturate, although no infravesical obstruction. Very important. I tell you something, please don't forget it, the transverse myelitis. Any case of acute retention there is without any infravesical pathology, don't forget the transverse myelitis and refer the patient for the neurological doctor for neurological assessment. Management of acute retention, as we said, when we said obstructed kidney or persistent colic, relieve the obstruction. The same rule. If the urethra is healthy, you can insert a urethral catheter. If the urethra, there is a problem in the urethra, you have to insert a suprapubic tube. Just relieve the obstruction. Later on, treatment is the treatment of the cause. If there is a stone in the posterior urethra, you can do urethrostomy. If there is prostatic abscess, you can manage whatever the cause. You can manage the cause of this obstruction after relief of retention. This obstruction develops slowly. It is not acute. The bladder is distended, stretched, very gradual over days or weeks. The patient, the bladder is full, and in clinical examination, you may find the bladder reach to the umbilicus. The bladder is containing 2 or 3 liters of urine. The presentation of this patient, frequency, diurnal enuresis, and diurnal and nocturnal enuresis, is very important to complain. Once you find the patient complaining of enuresis, whatever diurnal, and nocturnal, you have to put in your mind the chronic retention. When you examine the patient, you will find the bladder piriform cystic structure reaching to the umbilicus or even the fisternum. The etiology mostly is chronic infravesical obstruction. The most common cause of the chronic infravesical obstruction for those with benign prostatic hyperplasia. Treatment, you have to drain this bladder, as we said in acute retention, either drain from below or drain suprapubically according to the situation. But the drainage here is different from case with acute retention. You have to drain this bladder gradual. If you drain this bladder very rapid or sudden decompression, this will end with severe hematuria. So evacuation of the bladder in chronic retention should be done gradual decompression of the bladder. Infection is very important emergency in our department, and I think there is lectures in this issue. You took it before. Although you took the chapter of infection, but I have to stress in certain point. Obstructed infected kidney. It is an emergency. Once you find a patient with a fever, kidney is obstructed, and internal echoes by ultrasonography, you have to drain this kidney. The second point is the abscess. Either renal abscess is an emergency, prostatic abscess is an emergency, scrotal or what's called testicular abscess is an emergency. Perinephric abscess is an emergency. Don't forget all this category as an emergency, and the treatment is the treatment of the cause. Acute renal failure. It's a very important item. It's a very important issue to put in your mind, the acute renal failure. Acute renal failure is a rapid deterioration of the renal function over a period of hours or days, resulting in failure to maintain fluid and electrolyte homeostasis and to excrete nitrogenous waste products. It is characterized by progressive, very rapid, may be preceded by oliguria, and at the early stage it is reversible. The chronic renal failure is slowly progressive chronic deterioration of the renal function, and this will take several weeks. This is very important. It has three causes, either pre-renal cause, renal cause, or post-renal cause. The pre-renal cause is called prolonged hypovolemia. It is very important. It is due to severe hypotension. So if there is a bleeding, massive bleeding in any surgery, in female, during labor, during cesarean section, during any abdominal surgery, massive bleeding means prolonged hypotension. So the anesthesia should put your eyes on the urine output. Prolonged hypotension will end it by renal shutdown and acute renal failure. Even in pediatric department, dehydration, child with severe vomiting, diarrhea, prolonged dehydration also may be ended by renal failure. The renal cause of renal failure due to acute extensive renal parenchymal disease, acute tubular necrosis, glomerulonephritis. They are very important. The renal cause in cases, predisposed cases like diabetes, like hypertension. This patient had pre-renal, the kidney is liable for trauma with massive analgesia, with prolonged analgesia administration. All this can lead to acute renal failure as a renal cause. Post-renal, or what's called obstructive diuresis, this is our responsibility as a urological department. If there is bilateral ureteral obstruction, like bilateral ureteral stone, and the patient is anuric, no urine, periurethra, with empty bladder, we said acute retention, no urine, periurethra, with full bladder. Here the anuria is the obstruction at the level above the bladder, supravesical obstruction. This is very important. Or obstruction of a solitary kidney, stone in a solitary kidney. This will lead to acute renal failure. It is an emergency, and we are in need for rapid decompression of this kidney. Sometimes malignancy infiltrating both ureter, sometimes post-abdominal perineal surgery or gynecological or obstetric surgery like cesarean, but complicated cesarean with bleeding. They may ligate the ureter bilateral. All this situation can be ended with acute renal failure or obstruction. The clinical presentation, renal pain associated with renal pain is called renal colic, volume overload and electrolyte disturbance that occur due to renal failure. This may be ended with multiple systemic manifestation, GIT manifestation, the patient complaining of anorexia, nausea, vomiting, respiratory manifestation, acidotic breath, and the main respiratory sign. Maybe the patient may be associated with central nervous system irritability, disturbed conscious level, and even uremic coma. Cardiovascular manifestation like hypertension, generalized edema, congestive heart failure, and pulmonary edema. It's a very important manifestation for acute renal failure. Investigation for acute renal failure, urea and creatinine, very important. The cardinal feature of acute renal failure is decline in the glomerular filtration rate. In routine clinical practice, it is usually identified by a rise in serum blood urea and the creatinine level. Creatinine clearance measurement It's very important to assess the renal failure, and it will be associated with hyperkalemia, which is very dangerous, and acidosis. Radiological investigation, including abdominal ultrasonography, abdominal QB, which is not, it is only for the radiopaque stone. The main ministry for diagnosis of any obstruction or cause of obstruction is the CT urography. As we said, it can diagnose both radiopaque and radiolucent stone. It does not need colonic preparation. It gives us idea about the kidney, the other kidney, the ureter, the bladder, give us the idea about the urinary tract, but the disadvantage is still expensive when compared with the QB. Treatment of acute renal failure, very important. There is indication for dialysis. In case of pericarditis, the change in irritability, change in the mental status, hyperkalemia, acidotic breathing, fluid overload, and pulmonary edema, all these are indication for dialysis. As we said, treatment is the treatment of the cause. In case of perirenal, prolonged hypotension, prolonged bleeding, so you have to replace with blood transfusion. In case of renal cause, go for forced diuresis and aggressive fluid repletion with diuretics, loop diuretics as furosemide or osmotic diuretic like mannitol. If failed, the patient may take 2 or 3 sessions of dialysis. For those with post-renal cause, if the patient general condition is bad, like acidosis, disturbed conscious level, dialysis 2 or 3 sessions till improvement of the general condition. If the general condition is good, relief of the obstruction, as we said, with a temporal minimally invasive maneuver passing either from below ureteral catheter or percutaneous nephrostomy. Then after the general condition and the creatinine become normal, go for treatment of the cause. When we are talking about the urinary tract trauma, it is either renal, ureteral, bladder, or ureteral. Renal injury, the kidney relatively protected from traumatic injury, so considerable degree of force is usually required to injure the kidney. Because the kidney is protected with a perinephric fat, it is protected with the lower rib and the back muscle, so it is mostly protected from each side. The mechanism and the causes of injury: blunt direct blow may be associated with fracture, major trauma may be associated with fracture rib, acceleration, deceleration, road traffic accident, falls from a height, falls onto flank, or penetrating like knives or gunshot. Diagnosis is very important. If there is a blunt trauma to the back, major blunt trauma, motor car accident, penetrating wound. The clinical presentation: if there is a macroscopic hematuria, microscopic more than 5 per high power field, and the patient is hypotensive, penetrating chest, flank, and abdominal wound, all this situation in need for CT urography. Actually, we have to know that the abdominal ultrasonography, all cases of urology examined by abdominal ultrasonography, and cases of renal injury should go for contrast enhanced CT. Are the degree of renal trauma either grade 1, contusion, microscopic or gross hematuria, urological studies normal, or hematoma subcapsular not expanding without parenchymal restoration, grade 2 hematoma, non-expanding perirenal hematoma confined to the renal erythroperitoneum, or laceration less than 1 centimeter, parenchymal depth of renal cortex without urinary extravasation, grade 3 laceration more than 1 centimeter, parenchymal depth of renal cortical without colic system rupture or urinary extravasation, grade 4 laceration, parenchymal laceration extending through the renal cortex, medulla, and the collecting system, vascular, main renal artery or vein injury with contained hemorrhage. Last one, grade 5 laceration, vascular, complete shattered kidney or avulsion of the renal hilum, devascularizing the kidney. These are the grade of the hematoma. If the hematoma is closed and it is not extending to the pelvic cell system and the patient is stable, most of the cases need just follow up. If it is shattered, the grade 5 may need nephrectomy. most of the case, as we said, there is a protective mechanism for the kidney. Most of the case, non-operative management in 98% of the renal injury can be managed non-operative. Surgical exploration for grade 4 and the grade 5 more often require surgical exploration. If there is persistent perirenal bleeding, expanding perirenal hematoma, pulsatile perirenal hematoma, penetrating trauma, it's very important, usually need exploration but can be managed non-operatively if carefully staged with CT. Injury. The ureters are protected from external trauma by surrounding bone structure, muscles, and other organs. Very difficult that blunt trauma cause injury to the ureter. They cause external trauma or internal trauma. This is the more external trauma, intraoperative or internal trauma. It is very common during ureteroscopy. It's very important. The most common cause of ureteral injury, the iatrogenic. During ureteroscopy, there is the perforation, there is the ureteral avulsion, whatever the type, but it's associated with ureteral trauma. Ureteric injury, as we said, external trauma, it is rare. It is a need for severe force, penetrating wound like knife or bullet wound to the abdomen, lower chest, to damage the ureter as well as the other organ. Internal trauma, more common than the external. During the surgery, hysterectomy or oophorectomy, sigmoidocolectomy, cesarean section. Most of the ureter injured during this difficult surgery. The diagnosis of ureteric injury require high index of suspicious, like cases with difficult cesarean, the cases of both the hysterectomy and the patient come with obstruction or urinary collection. You have to put in your mind the ureteral injury. You may discover it intraoperatively if the surgeon is alert and know this complication can occur in different situations, may be diagnosed intraoperatively. Late, the urine is collected intra-abdominal and the patient may be presented with presence of urine in the peritoneal cavity seen by ultrasonography, and the patient presented with ileus, prolonged postoperative fever, unexplained fever, persistent drainage of fluid from the abdomen or the pelvic drain. The treatment of this obstructed or ureteral injury, very important. Don't forget these cases. You have to drain the urine collection, you have to put an oophorectomy tube in the kidney to withdraw the urine or what's called divert the urine from the direction to the injured ureter. Later on, after 1 month or 2 months, after the situation is get calmed down, you can go for surgery and repair this injury. It is either iatrogenic injury, transurethral resection of the bladder tumor, cystoscopic bladder biopsy, transurethral resection of the prostate, cystolitholepexy, cesarean section, especially an emergency. The bladder very common injured during cesarean section, especially in cases with multiple previous cesarean. There is adhesion and the surgeon cannot dissect between the gravid uterus and the bladder, and they are called for us many times in cases like this. Penetrating trauma to the lower abdomen. Blunt pelvic trauma is associated with pelvic fracture, may be associated with bladder trauma. It is either intraperitoneal perforation or extraperitoneal perforation. The peritoneum overlying the bladder had been breached along with the wall of the bladder, allowing urine to escape into the peritoneal cavity. In this situation, by ultrasonography or even by CT, we'll find the urine floating in the peritoneum, needs drain and exploration. Extraperitoneal perforation, the peritoneum is intact and the urine escaped into the space around the bladder, but not only the peritoneal cavity. If it is big amount, sometimes it is in need for drainage.